Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I'll be doing a quick recap on the topic of the hyperparathyroidism. So, you need to know what is primary hyperparathyroidism. Primary hyperparathyroidism is that where the pathology is directly within the parathyroid gland. And what will be the common etiologies? I'll discuss that. So, primary hyperparathyroidism is due to it is due to hyperfunctioning of the parathyroid gland, and most common cause of hyperfunctioning of the parathyroid gland will be parathyroid adenoma. That will be the most common cause for primary hyperparathyroidism. And the elevated parathormone then causes elevated serum calcium and low serum phosphate levels. That is what you will have in patients with primary hyperparathyroidism. And what is secondary hyperparathyroidism? Secondary hyperparathyroidism is that whenever there is hypocalcemia, any condition which will cause hypocalcemia, you take renal failure or you take in vitamin D deficiency, or whenever there is malabsorption, in all these conditions you have the presence of the hypocalcemia. So whenever there is hypocalcemia, that will stimulate the parathormone secretion to excess quantity. That is called secondary hyperparathyroidism. So secondary hyperparathyroidism, it occurs in response to hypocalcemia, and this hypocalcemia could be due to in vitamin D deficiency or the chronic renal failure. Now the serum calcium levels, they are low, and serum phosphate levels are also low in these patients with the secondary hyperparathyroidism. Right? Next. What is tertiary hyperparathyroidism? Tertiary hyperparathyroidism, it is seen with long-term secondary hyperparathyroidism, which can lead to hyperplasia of parathyroid glands and loss of response to serum calcium levels. Normally, whenever you give calcium, parathormone secretion will reduce or will stop. But in spite of giving the serum calcium, parathormone secretion is still on the higher side. And there is hyperplasia of parathyroid gland secondary to long-term hyperparathyroidism, and that is called tertiary hyperparathyroidism. Next. Now, what is the most common cause of hypercalcemia? Most common cause for hypercalcemia is primary hyperparathyroidism. It contributes to almost the 90% of causes of the hypercalcemia. And what is the most common cause of hyperparathyroidism? Just now I have discussed, right? The most common cause of hyperparathyroidism will be parathyroid adenoma. That will be the most common cause of hyperparathyroidism. But hyperplasia of all four glands can lead to primary hyperparathyroidism, right? Next. Now, what is the rare cause of the hyperparathyroidism? The rare cause, it includes the parathyroid cancer. Parathyroid cancer, it is a rare cause of this particular hyperparathyroidism. That is parathyroid carcinoma. Parathyroid carcinoma. Next. Now, you see the association of hyperparathyroidism and Men's syndrome. You need to remember that in multiple endocrine neoplasia type 1, you have the parathyroid adenoma or parathyroid carcinoma, and in men 1 you have pituitary tumors, parathyroid tumors, and then the pancreatic tumors. So please remember these 3 P's of the hyperparathyroidism. Next, you take men type 2. Even in men type 2, you have the presence of the hyperparathyroidism. So along with hyperparathyroidism, there is pheochromocytoma and medullary carcinoma of thyroid. They are seen in men type 2. Next. What are the clinical findings in hyperparathyroidism? See, in hyperparathyroidism, 50% of these patients, they are asymptomatic. And what are the bony abnormalities in hyperparathyroidism? Let me tell you, whenever there is increase in parathormone, that increased parathormone will cause bone resorption, and that will result in osteoporosis and pathological fractures. Okay, so the bony abnormalities, if you see, there is increased osteoclastic bone resorption, thereby there is decrease in bone density, resulting in bone fractures. And in that osteoclastic bone, let me tell you, there will be deposition of the fibrous tissue by the process of healing. Right? There will be deposition of the fibrous tissue by the process of healing. And that is called as osteitis fibrosa cystica. That is another bony abnormality in patients with the hyperparathyroidism. Now, so in these bones, you know that increased parathormone will cause bone resorption. And when you take an X-ray, you'll have the appearance of punched out lesions within the skull. Right? And these punched out lesions, it will appear as salt and pepper like appearance. Right? This will appear as salt and pepper like appearance. And they'll have bone pain, they'll have pathological fractures, they'll have swelling, deformity, there will be also areas of demineralization, there will be bone cysts and brown tumors. So these are all the bony abnormalities in hyperparathyroidism. Next. So you can see the X-ray of the skull where you have the punched out lesions within the skull. Next. Now, what are the urinary tract manifestations in hyperparathyroidism? So if you take the urinary tract manifestations, there will be presence of the hypercalcemia, right? And secondary to hypercalcemia, you have the presence of renal caliculi, right? There will be polyuria, polydipsia, stones, and the nephrocalcinosis with renal failure, right? Nephrocalcinosis with renal failure. So this will be the renal manifestations and urinary tract manifestations in hyperparathyroidism. All these manifestations are mainly because of the hypercalcemia. Next. What are the neurological manifestations in the hyperparathyroidism? They are all again due to hypercalcemia. That includes mild personality disturbances, severe psychiatric disorders, mental obdundation or coma. There will be neuromuscular weakness, easy fatigability, and then atrophy of the muscles. So these will be the neuromuscular manifestations that you will come across in patients with the hyperparathyroidism. Then what will be the gastrointestinal manifestation in the hyperparathyroidism? Gastrointestinal manifestations are because of hypercalcemia. That includes anorexia, weight loss, constipation, nausea, vomiting, thirst, increased thirst, abdominal pain with pancreatitis, and then the peptic ulcer disease. So these are the gastrointestinal manifestations that you will come across in patients with the hyperparathyroidism. Next, what are the cardiovascular manifestations? You know, these individuals will have hypertension and development of the arrhythmias, and they'll have short QT interval. The QT interval will be less than 360 milliseconds. That will be the cardiovascular manifestations. And how do you diagnose hyperparathyroidism? Diagnosis is by estimating the serum calcium levels, right? The serum calcium levels will be more than 11 milligrams per deciliter with elevated parathormone. And what will be the urinary findings in hyperparathyroidism? So there will be elevated urinary calcium levels, right? There will be elevated urinary calcium levels. But because of calcium reabsorption action of parathormone, 35% of the patients, they have the normal levels of the urinary calcium, but otherwise there will be elevated urinary calcium levels in these patients with the hyperparathyroidism. Next, what is the serum phosphate level in patients with hyperparathyroidism? They will have usually low serum phosphate levels, right? Low serum phosphate levels, okay? Because this increased parathormone will not allow the phosphate to be reabsorbed. So that is the reason why they have low serum phosphate levels. Then what is the differential diagnosis of the hyperparathyroidism? Differential diagnosis of hyperparathyroidism include hypercalcemia of malignancy, right? And in every other cause of hypercalcemia, parathormone level will be low, okay? Next. And what are the imaging studies for localizing the tumor? The imaging study is technetium 99M sestamibi scan. That will be the imaging study for localizing this particular parathyroid adenoma. Next. Now, when you combine with this next sonogram, the specificity rises in localizing the tumor. Next, what is the treatment for hyperparathyroidism? Surgical resection of the tumor. parathyroid adenoma, whatever is there, you have to remove it. That will be the treatment of choice in patients with hyperparathyroidism. And parathyroidectomy should be performed, right? Next, what is the indication for medical management? The indication for medical management is that in those individuals where surgery is contraindicated, then medical management has to be given. Or if serum calcium level is less than 11.5 milligrams per deciliter and the patient is asymptomatic, in them medical management has to be given. And what is that medical management that you will give? That is bisphosphonate, that is pamidronate. So this bisphosphonate will reduce the bone resorption, and that will be the medical treatment or medical management in patients with the hyperparathyroidism. Then, what is the dietary calcium in hyperparathyroidism? Obviously, you have to reduce the dietary calcium in hyperparathyroidism, because in hyperparathyroidism, the individual is having hypercalcemia. So you need to reduce the dietary calcium in patients with the hyperparathyroidism. And you need to give, right, you need to give the oral hydration with 2 to 3 liters of the fluid. So whenever you give 2 to 3 liters of the fluid, that will reduce or that will dilute the hypercalcemia. Next, how do you treat hypophosphatemia? Right, so these patients, they are having hypophosphatemia. So you need to give phosphate supplementation with phosphostor soda. That is how you will treat the hypophosphatemia. Next, in primary hyperparathyroidism, surgery is indicated if any of the following are present. That is, number 1, if there is symptomatic hypercalcemia, surgery is indicated. Calcium levels more than 11.5 milligrams per deciliter, surgical resection is done. Renal insufficiency, surgical resection. Age more than 50, nephrolithiasis, and osteoporosis. In all these clinical scenarios of primary hyperparathyroidism, surgical resection of the parathyroid adenoma has to be done. Next, what is the emergency treatment for severe hypercalcemia? Let me tell you, the emergency treatment for severe hypercalcemia include IV fluid along with furosemide. Right, IV fluid along with furosemide. That will take out the entire calcium which is present in the body. Okay, next. What about the bisphosphonates? Everyone gets IV bisphosphonate such as the pamidronate. This pamidronate, whenever you give, it will reduce the bone resorption, and thereby it will reduce the serum calcium levels. But these bisphosphonates, they are useful only temporarily for hyperparathyroidism, and it may take almost 2 to 3 days to reach the maximum effect of the bisphosphonate. Right, it may take 2 to 3 days to reach the maximum effect of the bisphosphonate. Next, now you have an important syndrome in hyperparathyroidism called hungry bone syndrome. What is this hungry bone syndrome? Hungry bone syndrome is hypocalcemia that occurs after surgical removal of the hyperactive parathyroid gland. Okay, once you remove parathyroid gland, the normal osteoclastic activity will not be there. So because of that, there will be hypocalcemia. That is what is called as the hungry bone syndrome. Now, what are the manifestations of hungry bone syndrome? There will be decreased calcium, there will be decreasing phosphate, and as well as magnesium 1 to 4 weeks after post-parathyroidectomy. That will be the manifestation of hungry bone syndrome. And what is cinacalcet? Cinacalcet is a calcimimetic agent that has some effect in hyperparathyroidism by shedding of the parathyroid gland. Next, what is indication of cinacalcet? Mainly patients with parathyroid carcinoma who are unamenable to surgery, in them we give this cinacalcet. So that is about the hyperparathyroidism. Thank you very much.